Hello and welcome back to Derm School. Today we shall be looking at urticaria and vasculitis. This is the outline of what we're looking at today. For urticaria, besides an introduction, we will be covering a few entities, namely acute urticaria, chronic spontaneous urticaria or CSU, as well as chronic inducible urticaria. Next, we shall look at vasculitis. So firstly, urticaria. Now, what is urticaria? It is defined as the presence of wheals, which are transient edematous papules and plaques. These are superficial, well-defined, and pruritic, and these are characterized by edema of the papillary dermis. There can be a wide distribution of the skin lesions. Next up, angioedema. Angioedema involves a larger edematous area due to involvement of the dermis and subcutaneous tissue. It is deeper and ill-defined. It can be localized, particularly in areas such as the face, especially eyelids and perioral, the hands, feet, genitalia, tongue, uvula, soft palate, as well as the larynx. Acute urticaria is defined as urticaria with or without angioedema lasting less than 6 weeks. Wheals usually last less than 24 hours, and severe allergic urticaria can lead to anaphylaxis. The causes of acute urticaria are viral infections such as upper respiratory tract infections, hepatitis, and infectious mononucleosis. Next, bacterial infections such as dental abscess, sinusitis or mycoplasma, food allergies which are IgE mediated, examples milk, egg, peanut, and shellfish, drug-induced urticaria which is IgE mediated to antibiotics, drug-induced urticaria due to pseudo-allergy such as aspirin, NSAIDs, opiates, and radio contrast media, vaccination, bee or wasp stings, and widespread reaction following localized contact urticaria can occur with latex. An allergy test is only indicated if suspected type 1 food allergy or drug hypersensitivity, such as to NSAIDs. Treatment is with oral second-generation antihistamines. This can be increased up to 4-fold of the dose if the standard dose is not effective and should be given continuously. Avoid trigger factors. If refractory, the patient may require a 4 to 5 day course of oral prednisolone. And in cases of anaphylaxis, intramuscular adrenaline should be administered. We shall now look at chronic spontaneous urticaria. Chronic urticaria refers to urticaria lasting 6 weeks or more, usually with 3 to 4 episodes per week. Chronic spontaneous urticaria is when you cannot identify any known cause, as compared to inducible urticaria. In urticarial vasculitis, the lesion would last more than 24 hours and there may be the presence of post-inflammatory hyperpigmentation. So in order to exclude urticarial vasculitis, make sure the lesion lasts less than 24 hours for each individual lesion and no post-inflammatory hyperpigmentation is present. The following are associations with CSU. Chronic underlying infections such as Helicobacter pylori and bowel parasites, chronic autoimmune diseases such as SLE, thyroid diseases, celiac disease, and vitiligo, as well as lymphoma. The pathophysiology of CSU. The type 1 autoimmune response is also known as the autoallergic response. Here, the presence of autoantigen in the skin can form a complex with IgE and activate mast cells. For example, IgE autoantibodies to autoantigens such as interleukin-24 or thyroid peroxidase TPO. These IgE autoantibodies then bind to high-affinity IgE receptors and can be cross-linked if antigen is present. While the type 2b autoimmune response is due to the presence of IgG and possibly IgM antibodies to the high-affinity IgE receptor or IgE cross-linked high-affinity IgE receptor or high-affinity IgE receptor-bound IgE respectively. There is then activation and degranulation of the mast cell, leading to the release of histamine and the presence of CSU symptoms such as itch, hives or urticaria, as well as angioedema. Investigations for chronic spontaneous urticaria include full blood count with differentials, ESR and CRP, IgG anti-thyroid peroxidase, as well as total IgE. The following tests are only ordered if indicated: H. pylori testing, functional autoantibodies or the basophil test, thyroid hormones and autoantibodies, skin tests and or allergen avoidance tests. In severe systemic disease, you can consider tryptase, and others include lesional skin biopsies, particularly if you suspect the presence of urticarial vasculitis. In terms of the treatment of chronic spontaneous urticaria, you first start with a standard dose of second-generation H1 antihistamines. If needed, increase the dose up to 4 times the usual dose. If there is inadequate control on high dose, after 2 to 4 weeks or earlier, if symptoms are intolerable, you can add on omalizumab. The dose is usually 300 mg every 4 weeks, and if needed, this dose can be increased and or the interval of dosing shortened, and this can go up to 600 mg every 2 weeks. If there is still inadequate control, within 6 months or earlier, if the symptoms are intolerable, you can add on cyclosporine. In addition, a short course of glucocorticoids may be considered if the patient develops severe exacerbations. We now look at a few types of chronic inducible urticaria, such as cold urticaria, delayed pressure urticaria, heat urticaria, solar urticaria, symptomatic dermographism, vibratory angioedema, aquagenic urticaria, cholinergic urticaria, as well as contact urticaria. For patients with chronic inducible urticaria, full history taking needs to be performed, as well as certain tests might be indicated in these cases. And besides standard treatment of urticaria, the patients should avoid these triggers. We now move on to vasculitis. This is the revised Chapel-Hill criteria for vasculitis. Vasculitis in itself refers to inflammation of the blood vessels, and it can be divided into a few major categories. For large vessel vasculitis, Takayasu arthritis, vasculitis of medium vessels such as polyarthritis nodosa or Kawasaki disease, small vessel vasculitis, immune complex vasculitis such as Henoch-Schönlein purpura, cryoglobulinic vasculitis, as well as hypocomplimentemic urticaria vasculitis. NCAR-associated vasculitis include granulomatosis with polyangiitis, GPA, eosinophilic granulomatosis with polyangiitis, EGPA, as well as microscopic polyangiitis, MPA. Other types of vasculitis within the criteria are variable vessel vasculitis, such as Behçet's disease, single organ vasculitis, such as cutaneous leukocytoclastic anginitis, cutaneous arthritis, primary central nervous system vasculitis, isolated aortitis. Vasculitis associated with systemic disease includes lupus vasculitis, rheumatoid vasculitis, and sarcoid vasculitis, as well as others. And vasculitis associated with probable etiology includes hepatitis C or B associated vasculitis, syphilis-associated aortitis, drug-associated immune complex vasculitis or ANCA-associated vasculitis, as well as cancer-associated vasculitis. Hypersensitivity vasculitis is one of the most common forms that we see, and it is also known as cutaneous small vessel vasculitis. Etiology includes drugs, infection, vascular or connective tissue disease, as well as paraproteinemia. In this condition, there is deposition in the post-capillary venules of circulating immune complexes. Patients may not have any symptoms, but they may also complain of pruritus, burning pain, fever, malaise, peripheral neuritis, abdominal pain due to bowel ischemia, arthralgia, microhematuria due to kidney involvement, as well as central nervous system involvement. The typical skin lesions are palpebral purpura, as you can see in the picture below. Investigations: full blood count is needed to rule out thrombocytopenic purpura, ESR, serum complements, urinalysis looking for red cell cast as well as albinuria, skin biopsy, and check for underlying diseases such as connective tissue disease screening. Treatment is often with prednisolone, which is a systemic corticosteroid, as well as the presence of steroid-sparing agents such as azathioprine, cyclophosphamide, cyclosporine, IVIG, infliximab, rituximab, and antibiotics if it's due to bacterial infection. Next, a very common condition, especially among children, is Henoch-Schönlein purpura or IgA vasculitis. This can also affect adults, and it is due to Streptococci group A upper respiratory tract infection. Clinical manifestations are palpebral purpura, bowel angina or ischemia, and kidney involvement such as with hematuria, red cell cast, and progressive renal disease, as well as arthritis. So the take-home message: we need to identify skin lesions, differentiate acute from chronic urticaria, and be able to diagnose urticaria vasculitis, remembering that the duration of individual lesions in normal urticaria should be less than 24 hours and should not leave any post-inflammatory hyperpigmentation. Also know the Chapel-Hill classification for vasculitis, as well as identify and treat underlying causes and conditions. So that's all about urticaria and vasculitis, and thank you for your kind attention. See you again on Derm School.